So with philosophy, all I realized we are getting all the very high velocity comminuted fractures. We are getting we are getting senior citizens with very porotic bones, and we know there are high rate of failure for Philos fracture also, though it is still a golden standard. And all the nailing results are still compared with the Philos plating. So we know in humerus, proximal humerus, it's not only the approximating bone fragments, it also soft tissue, reconnecting all the rotator cuff, because humerus has been described as a unique mobility, shoulder joint. So we have to reattach all the tendons properly to achieve good functional result also. It's not only radiological result that matters in shoulder. So as this paper says, there has been a very high complication rate. This was a 2011 publication, I think. There is a high rate of complication and almost 13.7 reoperation rate with Philos. And most common complication was screw problem and also impingement for wrongly placed plates. And surgery is definitely more traumatic than a percutaneous nailing. So it involves a lot of tissue dissection, a lot of blood loss, and this is the example of how the humerus, sometimes the head collapses and Philos plate screws being a pointed screw, they jet into the joint and cause pain and sometimes implant removal. So we all know, we have been using nails for all long bones. We know that we have accepted it very much. We have replaced our DHS with a PFN in subtroch and neck femur fracture. But we are still reluctant to use it for proximal humerus fracture. So we know the pros of the nails, that it allows it gives a better stability, rotational axial loading than a plate, being more centrally located than eccentrically located plate like Philos. And so we have accepted this function in proximal femur. We rarely open the femur fracture. And this is how the nail functions in humerus also. And this is we have accepted its role in the shaft humerus fracture. But when it comes to the proximal 4-part, 3-part and proximal neck humerus fracture, surgical fracture, we are reluctant to use the nail. Like shaft fracture, we are using it regularly. In porotic patient, we use the multi-hole nail. But probably our design in the initial first generation and second generation nail was not good enough for proximal fractures. There was no multi-lock system. There was no locking screw, bicortical compression screw. There was no calcas screw in primary first generation. Second generation AO nails were multi-lock nails, but the entry point, they were bent nails, and they had a proximal bend, and they used to cause a problem like impingement of supraspinatus tendon because the entry site was from the footprint of the supraspinatus rotator cuff. And even the screw design was such that it used to cause impingement. It used to back out because of poor hold in the cortical bone, lateral cortex bone. It used to bury in the screw sometimes, bury in the cortex, lateral cortex. And screw perforation was also common like in Philos. So in 2011, the multi-lock proximal humerus nail was launched with specific design. It was designed specifically to address the proximal humerus fractures. It has many additional facilities, new design modules as compared to the AO previous multi-lock nail. Like it was a short and long nail, short for proximal humerus fracture specifically. It has these specific new designs. It was a straight nail. Firstly, it was a straight nail. So it used to not go from the fracture site, because the fracture site, GT fracture used to be at the groove between the GT and the head, and the entry point was slightly more medial, few millimeters medial. So it used to not go through the fracture site. It is not supposed to impinge, because of that doesn't impinge the supraspinatus footprint. So even the impingement and abduction problem post-op were rare. Then there was a unique screw-in-screw design specifically designed for the porotic patients, senior citizens above 65, 70, and it gives additional stability and less screw back out. There was a polysilicon inlay in the nail to allow better purchase of the screw in the nail also. And there was also ascendic nail, ascendic screw option, 4 mm screw option, like a calca screw. There's a multiplanar distal locking. So many more features are added to give it a better stable fixation. So this is how it was designed. Since the purchase was much more, it's from the actually it's from the articular cartilage of the head. It's few millimeter medial to the groove between the GT and the head attachment. In fact, there are 4 interlocking screw options, and in fact, this is considered being a cortical bone there, better bone than the lateral cortex. It is actually considered like a 5th purchase, 5th cortex. So it gives a 5th interlocking screw purchase. So this is how the standard techniques do apply. The approach is anterolateral approach, as Dr. Raman has described nicely. And in an obese patient or difficult fractures, you also detach part of the deltoid from the clavicle and acromion. So you take this approach, and like standard approach, you take the parachute stitches when there's a 4-part or 3-part fracture and control the reduction with those. And also you can use abundant use of K-wire to use as a joystick and have a good reduction. Once you achieve a good reduction, you decide the entry point. One more feature in this screws also is that this screw is conical, like a conical bolt laterally. So it has a good purchase. You have to bury it inside. So it has a good purchase on the lateral cortex, being a conical design, and there's a threaded conical design. And also it has 4 holes to tie the rotator cuff once you finish with the fixation. So it has the holes pre-designed to tie your parachute stitches and rotator cuff. So this is one of the clinical example of how proximal fracture was treated effectively. You can see those conical lateral head of the conical bolts of the lateral portion of the screw are better purchased, and they are countersunk into the cortex, so they don't impinge the deltoid also. And this is how proximal hole, one of the example again, how the screws perforate. And though on table we rotate this and take 360-degree view of the screw is not purchasing, quite often there is a collapse. And after the collapse, the screws enter the joint. So multi-lock, why I am showing this slide again is the multi-lock screw. The new nail has the tip which is not pointed, it is a blunt tip. So it has less chance of going into the joint, and plus big purchase being good inside the nail, in the lateral cortex also, so you don't have to literally go subchondral. Whereas in Philos, you literally have to be subchondral for some purchase. So here you can be 2-3 millimeter away in a safe zone to avoid the screw entering into the joint if in an unfortunate circumstance like a head collapses or a fracture site collapses. So this is how the screw-in-screw technique also. That is one of the big inventions, is screw-in-screw technique. You can put in from the lateral, from anterior screw you should not, there are 3 lateral screws in this nail. So you can choose any screws to have a screw-in-screw fixation for additional stability. The additional screw of 3 millimeter, 3.5 millimeter I think, which goes outside the nail in a better bone area. You can choose which is the better bone area by rotating there's a guide sleeve, and there's an arrow on the guide sleeve. And you can choose which side you want to go. But generally, commonly the posterior part has a better bone stock. So you go like this. You go put in the screw-in-screw more on posterior side. That is a general consensus, and it's proven. So there are many comparative studies. Dr. Sachin, there's a lot of comparative study between plating, Philos and this. So most of the studies are retrospective studies. And in this study, there were some 84 patients, and the results were equivalent. Actually, the results were equivalent, but it was proven beyond doubt that operative time was less, blood loss was less, incision was less, so morbidity was less, and patient could be mobilized earlier. The long-term results were not much different in this study between the plating and the nailing group. There were 82 patients were taken for the study. So as you see, multi-lock nail is, the treatment was same, all the score wise, but it's superior because less blood loss, less operation time. So for morbidity, people who have morbidity, old patient is a better idea. Similar studies, I found many studies in literature. There's one meta-analysis also. The most of the studies are comparable, but only thing the nail scores over the plate is that early mobilization, less blood loss, and less incision, many incision in this surgery. So it's a biological fixation. So you can go through this, that the Philos had more reoperation rate, whereas the nail group had less reoperation rate. So even in this study, it is compared the similar way that you can just go to the conclusion similar outcome, but in the elderly patient population, low rate of secondary loss of reduction and screw cutout. So it has less secondary screw cutout.
Thank you, sir.
And reduction loss is much less. So all the standard technique I did not describe again, because the only one thing which I want to emphasize is that when you are putting a straight nail, initially there is a learning curve. You find it difficult to find the entry point. So idea is, initially they are suggested you go for typical beach chair, but that takes a lot of time to set up. So supine position, what we do for philos, with a pillow or a pillow which is radiolucent behind the shoulder blade, and you check everything that you are seeing it proximal to distally, check it before you take your incision, and you have to extend the shoulder. Once you extend, you get the entry point. The entry point is slightly more medial. It is just lateral to the biceps tendon and posterior to the bicep tendons. It comes in the same line as the shaft. So this is the entry point. It's medial to the sulcus of the GT. So these are the cases which we have treated. I'll just show one case which we've done. This is a case which we done in Jupiter about a year ago. So here a complex fracture, proximal humerus extend into shaft, and we chose this implant. This is a CT scan. We chose this implant. We could not think about any other implant like a long philos plate, because the patient was very high risk patient. So this we did it, but we had to do open reduction for the distal fragment. After nailing also we found there's instability. So we put a sacrilege and a bone graft there. So there are many of these patients who are, we think we used to do like coxophumeral bypass, Dr. Lard says, we used to think about them as for replacement. But probably with this nail, I can still think of doing a conservative surgery instead of the replacement. Thank you.